believe we are here. I think we're just going to wait a few minutes for some people to pop in. But hello, everyone. We're here with Dr. Gassman. This is Tabitha with PRMA Plastic Surgery. I'm a patient liaison here. If you ever have any questions about Pink Ladies meetings or anything like that, feel free to reach out to me. Most of you have my email. If not, you can just call the office and ask for Tabitha. We are here with Dr. Gassman tonight. Say hi, Dr. Gassman. He's going to be talking about body contouring and just any questions about reconstruction that you guys may have. Go ahead and leave them in the comments. I'm kind of following along there and going to be asking him whatever you're asking me. So we got a handful of people on here. Let's just wait a few more minutes and let a couple other people join. In the meantime, Dr. Gassman, do you want to tell us a bit about you and how you started here with PRMA or when you started?
Yeah, that'd be great. Yeah, so I'm Andrew Gassman.
That's me. Sorry. I flipped it when I was trying to zoom.
Okay. I'm Andrew Gassman. I'm one of the newest associates here at PRMA. I recently moved to the area here to join the practice. Prior to this, I was an associate professor teaching plastic surgery to young plastic surgeons up in Philadelphia. I trained pretty much all over the country, originally from the East Coast, and then went to college in Massachusetts at Holy Cross, and then did some time in research down in North Carolina, at University of North Carolina. I went off to medical school at Loyola in Chicago, and I stayed there for my general surgery training and some research time. After that, I traveled on to Los Angeles, and it was at UCLA, and that's where I did my plastic surgery training and did subspecialization in microsurgery and breast surgery and aesthetics at University of Texas Southwestern in Dallas. And then
turning you so it's not awkward for everybody watching because it's kind of sideways on them.
Oh, sure. And then I went into an academic practice and was there for several years, and met the group at various academic meetings, and we seemed to be very like-minded and similar interests, and they recruited me, and here we are.
Awesome, you got suckered in. Well, let's kind of get into it a little bit. We're here to talk about body contouring, so we'll go with the first question that we have on the list. Who is eligible for body contouring? Is it only people who are getting DIEP flaps?
No, so I have an aesthetic background as well, and I try to incorporate a lot of that in how we do breast reconstruction, and specifically abdominally based reconstruction. Mm-hmm. But there was a philosophy that was taught to me in training that basically all surgery ends up aesthetic, and so when we do our closures and when we finish the procedure, we try to make everything look as beautiful as possible. The advantage here is that when it's either abdominal or thigh-based donor tissue, these are areas that are commonly sought after for body contouring and aesthetic procedures, and so lending some of those techniques, we can get additional benefits. Most people consider the DIEP as a tummy tuck, the thigh flaps as thigh-plasties, but there are a lot of things that we've learned from those aesthetic procedures and those that advanced in recent years that we can apply, and those happen both in the initial stage and also in the subsequent revision procedures.
Awesome. And I have another patient asking, is it important for someone to be at their goal weight before they have body contouring? I'm assuming this is relevant in like a revision stage? Mm-hmm.
Yeah, I think I'm conservative in that regard, that whatever the surgery is, I prefer that patients are who they are. And I'm not a firm believer in major, dietary and modifications that are temporary, like adding weight just for surgery only to lose it later. For better or for worse, you can't fool the body. And so for me, it works better if somebody is where they're trying to be, and the goal weight is ideally where that person's going to be afterwards. There were many body contouring procedures I've done in the past where we removed 30 pounds in one surgery, 40 pounds in one surgery, and that weight can come back if there aren't other changes. They can't fool the body. So it's important to know that that weight is has to deal with somebody's diet and exercise plan, and that what we do is really improving contour and shape. And so ideally patients are where they want to be prior.
Yeah. What stage of the reconstruction is the body contouring done?
That's a great question. To me, it really happens day one. We do a lot of our procedures as immediate reconstruction, so the tissue is taken from either the abdomen or the thigh, and in that initial phase where I'm already doing added components to the procedure that will really improve waistline and overall figure. But where things get really exciting is where we start adding concepts such as 360 liposuction, high definition liposuction to that during the revision phase if we're using these areas for fat grafting sources.
So the big question a lot of people want to know is that covered by insurance? All the liposuction, the 360 lipo, all that stuff?
So the short answer is a good deal of it. The majority of it, I would say, but there is a fine line, because there is how much we need for the overall breasts, and then if we are talking about substantial liposuction beyond that, then that could be an area where the insurance company would get concerned. But that's really personalized on a case-by-case scenario. I would say, oh, sorry.
Something that people can do, like where they can pay for the cosmetic portion of it?
Yeah, there's fortunately that's if there is an added expense, a lot of the other components really are incorporated with the reconstructive components. The good news and bad news with fat grafting is that 50% of what we inject generally survives after 6 months, and I always say that's for a population average. That means some people it's 80%, some people it's 30%. But that means then, in my approach, is that I inject more and hope to land where we always wanted to be. And that means that we have to get more. And so it becomes this process where I actually have to do a decent amount of liposuction to get to the goal that I'm hoping for, so that ideally it's a single stage for the revision, as opposed to constantly coming back again and again and again.
That makes sense. So that was the other question, can it be done in one stage?
So for fat grafting, ideally that's a single stage, but to really get the most benefit for body contouring, that often's done in both a initial reconstructive phase and then the revision later. You know, breast reconstruction, depending on body habitus, everything could be done in one stage, but a lot has to line up in terms of body habitus and a lot of things. But I tell people in all reality, there's usually 2 stages, but we can really maximize each one of those stages.
Okay. Can the contouring be done years after DIEP? So in another word, can it be done with revisions instead of DIEP if they've already had a DIEP?
Oh yeah, definitely. So, you know, lending what we know about high definition liposuction and body contouring, these are principles that can be applied years later, but the impetus there is that for us to gain fat for high volume fat grafting with these other great benefits.
What is the recovery like for lipo with DIEP or just on its own?
Yeah, so that varies from person to person. I always describe liposuction for the fat grafting as a little incision, big surgery. And we use a lot of numbing medicine that's both short and long-term acting, in addition to our enhanced recovery pathway. So over the years, I would say, you know, the recovery is as smooth as it's ever been, or if not better. But I can't guarantee that there would be zero discomfort, and that's something that we kind of customize on a case-by-case scenario.
And I think I've heard that for patients too, just the revision stages tend to be a little bit more discomfort than the actual DIEP just because of the lipo.
Yeah, I think there's a larger area, but also I think part of it too actually is expectation, because people don't realize that even though it's an outpatient procedure, the revision does cover a large part of the body.
Yeah. And then, so that's kind of most of the questions we've gotten about body contouring. I have some other questions just about reconstruction in general. If anybody on the live still has any questions about body contouring or anything we didn't cover, just go ahead and throw them in the comments and I can ask when we're all done. But I have a patient asking about DIEP flap surgery. So she is having surgery soon, and she's just wants to know how much help we tell people that they're going to need after surgery. So is she going to need somebody with her 24/7? How does that work?
Yeah, so recovery after these types of procedure, the first few days are the hardest, and definitely the first week you would definitely need help. It's hard to say exactly because everybody recovers a little bit differently, but it would be very useful to limit any sort of major exertion that needs to happen around the household. That could be as simple as, picking something up off a low shelf to having to move a piece of furniture or something like that because the remote fell back there. Any number of reasons. But what the good news is with enhanced recovery pathways, these processes are easier and easier. Each week really does get substantially better.
I had someone just ask, how often do patients get sent to PT after DIEP flap reconstruction?
I can't say never. Fortunately, it's not that frequent. PT is mainly required if we're concerned sometimes with edema or related to the flap itself. The actual process of transferring can be quite inflaming for the tissue, and if it feels a little bit more swollen than we'd like, we send patients for massage therapy and things like that that helps soften the tissue and really prepare for second stage. But in terms of rehabilitation for, muscular components or something like that part's not as frequent.
Okay. What about for patients who are losing weight to get to a better BMI? She said she's fearful to lose too much weight, to not have enough tissue for a breast size.
So that's an interesting one.
Is there anything of losing too much weight?
Yeah, so there is. But this kind of goes back to the prior question. Ideally, you're in a healthy place and your weight is where you're going to be. The only exceptions we'd run into that are people that I would say are on the heavier end where their BMI is pretty high, and we start to run into wound complications mainly from the donor site when there's people have elevated BMIs that can be in the 35 or 40 range. And in those cases, those individuals will generally have sufficient tissue for a reconstruction, and that wouldn't necessarily be a concern. But definitely during the time of the operation, getting below those thresholds will help limit wound complication for sure.
What about back to fat grafting? Can we only take it from the flanks? Can we use fat grafting from the buttocks? What other areas can we do?
Yeah, so there's a lot of options. So my approach is to look at the patient 360, and so the flanks are just one area. This adds a little time to the operation because there's repositioning involved. And we take it from the upper back, the lower back, sometimes the arms, I don't necessarily take from the buttock itself, but we take from around it, so at least the posterior area gets some aesthetic benefit as well. It can come from the thighs, but there's many areas where it can come from. At times I'll also take it from the prior abdominal area as well to give additional contouring and benefit there, so that it's not just flatter, it also has a better toned appearance.
Okay. How long does this swelling last in the breast after surgery?
Good question. That's variable, and the earliest I would say that someone can say that the majority of their swelling has resolved, it would be in the 3-month category, but most people it's in the 3 to 6. And for some people, they just have difficulty with resolution of their swelling, and that would be closer to a year. But you know, the 3 to 6 time mark is usually a pretty good estimation.
What about necrotic tissue? How is that dealt with in phase 2?
So necrotic tissue.
And what is that for some people?
Yeah, great. So necrosis is essentially dead tissue.
Right.
And ideally that's dealt with prior to you know, fat grafting and any additional procedures, because it in and of itself is inflammatory and will lead to additional swelling and contour change. That being said, if there is some of that around, it's not the end of the world. We just have to get rid of it and close it. And how that's done is sort of done on a case-by-case scenario on where it is in the body, and there's many kind of workarounds to that.
So we get this question a lot actually. One, how does weight loss and weight gain affect your reconstructed breast that comes from your tummy tissue? And specifically this one is if she's only having unilateral reconstruction, how would it affect maybe her weight loss and weight gain in her natural breast and her reconstructed breast?
Mm-hmm. Yeah, that's a good question. So we do know that fat has a memory and has a memory of the tissue that it came from. Just a little anecdote, this science actually came from when people were doing fat grafting into children that had conditions where they didn't have fat in their face, and when they would gain fat later, the side that they corrected would grow quite a bit. And if there's a particular area of someone's body where they gain and lose weight the most, and that's used as the donor source, whether it be from a DIEP or from a thigh flap or from fat grafting, that tissue that takes will take on that same behavior. So if someone's abdominal area fluctuates in weight more than their breasts do, then there is more chance for fluctuation in that with the reconstruction, either be it a free flap or with fat grafting.
What is high definition fat grafting?
Yeah, so I guess the terminology I'm coining is a high def DIEP, but what we do is we lend concepts from aesthetic surgery, where we're doing high definition liposuction at the secondary stage, and at the initial phase we're doing some additional what we call plication, which is a way in which we close the abdominal area, and that has a few benefits. One, it recruits tissue from the waistline, it recruits tissue from the upper abdominal area, and these give very nice contours. But secondary benefit and great clinical benefit is it closes down the area for the space for fluid to collect, that the fluid that you need to have drains for. It closes that down so that the drains are potentially removed much faster. So it's really win-win all around.
Yeah. Sorry, there's a big old truck. I don't know if they can hear that. Got loud. So if there's not enough tissue in the abdominal area, what can we use other areas at the same time? So I'll do 2 separate flaps during phase 1.
Yeah, that's possible. So the options are, yeah. So the options are that we would do what's called stacked breast reconstruction, and it's possible to take multiple free flaps and connect them to create a breast with additional vascularized tissue. Alternatively, we can use a single free flap and use that as a starting point, and that really is the best substrate for which we can then add fat graft to it. The added advantage with that is with the fat grafting, we can then access fat over a broader area of the body for increased volume.
If somebody does the unilateral reconstruction and their breasts don't match, can we alter the other breast in the revision stage, or
Yes.
we match the DIEP to match the natural?
Yes. So in general, tissue matching tissue is one of the best matches you can have. We run into some limitations with matching tissue, whether it be a DIEP flap or even native breast tissue that hasn't undergone surgery, to an implant. I can make them look very good and near symmetric on the table, or near mirror image, I guess, on the table, symmetric overall. But in time, thanks to gravity and life, they will slowly diverge and become more and more different. But tissue behaves like tissue and will age similarly.
Okay. If a patient had a mastectomy years ago, she wants to have her implants removed, if she does the DIEP, does she have a chance of having sensation back?
Yes. So during the elevation of the DIEP flap, we find the nerves of the abdominal wall, and those routinely are taken with the tissue and the blood vessel. We find the nerves of the chest wall and connect them with minor exception. The exception would be if for some reason connecting the nerves compromise the blood flow or the blood vessels that are making the whole thing work. Then that would be the only reason we would avoid that. And at that point, once the nerves are connected, the nerves are then allowed to grow through that path and essentially take over the nerves that were previously of the abdominal area for the opportunity for resensation.
Okay. I know we talked about recovery for phase 1. What about recovery for phase 2?
So recovery for phase 2 is a little bit different in as much as there's much more likely to be compression and compression garments, particularly if we're talking about one of these high definition cases. And you know, the discomfort there is distributed over a larger area. I would still echo that you know, a patient would need some assistance definitely for the first few days, but each week that gets progressively better and better. But I would definitely urge for assistance. And for all my patients, you know, they always ask, how much time should I ask for work? I always recommend asking for more and to go back early looking like a hero.
For someone who had a DIEP flap years ago, can she have another stacked flap if she's not satisfied with her size, or fat grafting the only option?
It is possible, but that's done on a case-by-case scenario, because the other considerations are what blood vessels are still available to connect the new tissue to. So more than likely there would have to be some additional imaging study to make sure that there's a sufficient place where we can actually connect the new flap tissue.
Someone else said she's 11 weeks post-op, phase 1, holding a lot of weight in her legs, and legs. She said she's about 10 pounds over pre-surgery weight. Is that kind of normal? Could that be affected with swelling? Yeah,
I mean, that to me sounds very much like edema and post-operative swelling. That fluid should equalize in time. You know, there's a lot of specifics in there that you would have to be kind of worked out to make sure. But I think that's all that is. But yeah, there's many ways to take that. Yeah, I would definitely follow up and make sure that that's being tracked.
Okay. Any drains in phase 2?
Yes. So with the high definition liposuction and body contouring, we will use drains. Those don't typically last nearly as long as they do in phase 1. The emphasis there is for the tissue to have all the fluid removed that we actually put in, and then additionally help limit what's called a seroma, which is a fluid collection that can happen within the area of the liposuction. Just as an aside, to do liposuction, we actually instill quite a bit of fluid that has both numbing medicine and medicine that actually helps prevent bleeding. And a lot of that stays in the body for several days afterwards. And the point of the drain is to help that remove from the body more rapidly. And for any fluid that can build up in the areas where the liposuction cannula is, for that to quickly exit so that the body heals in more rapidly.
Okay. We have a lot of questions still coming in, guys. We don't have a whole lot of time left, but we'll get to as many as we can. If we don't get to answer them all now, I will go back through and try and answer the best I can, or ask Dr. Gassman to help fill out some questions in the comments. Let's see, what is the time frame for sensation to be felt in the reconstructed breast?
So typically a nerve regenerates roughly around, in an ideal circumstance, about 1 millimeter a day. And that means that the nerve needs to go about 3 to 4, sometimes 5 centimeters to get into the tissue, and then the thickness of the tissue. So that could be several months before it is where it is very sensate at the skin. A patient would know that things are coming online when they start to have kind of an unusual feeling start, and sensation coming back can be anything from an itching sensation, a burning, kind of a dull, strange feeling. It can feel like many things, even electricity sometimes some people describe, but that's a sign that sensation's starting, but the actual sensation at the skin level can be several months.
Does everybody have to have liposuction in phase 2?
No. So,
That's an easy one.
yeah, that one's easy. I mean, this isn't a cookie cutter thing. This is on a case-by-case scenario, and you know, some patients are in a phase of their life where they're just not interested in that, and that's fine. But it's just something for those patients that are looking for a little extra that we can offer it.
This is a great question. Once we're fully recovered from all of our phases, do we need to wear a bra, or can we go free?
Great question. I hope that you have that option.
Yeah. This one is, if I had a flap, why is my incision in the middle of my stomach? So I'm assuming maybe it sounds like high perforators.
Yeah.
There's not a lot of backstory there, but.
Yeah. So, I mean, to take tissue from the abdomen, I always say it's like a tummy tuck. It's not exactly a tummy tuck. And to make it all work, it's all about the blood vessel. And so if that blood vessel, the best blood vessel that'll make it work, came out high in relation to, say, where the belly button or umbilicus is, you know, that would be a high starting point. That scar could be lowered in time in a revision procedure, but that, you know, is basically anatomy.
Yeah. Is it guaranteed that everyone's going to get sensation back?
No. I mean, frankly speaking, because there's a lot of biology that's involved. Additionally, you know, particularly in a delayed setting, if there had been prior radiation or other elements too, that can limit the rate in which nerves regenerate. And there are unfortunate cases sometimes where nerves continue down the path, but eventually just kind of stop progressing. And there's no way of predicting that. That's also in a case-by-case scenario. Doing these procedures at least opens the opportunity for resensation.
A couple more. Let's see. Does the hospital send you home after surgery with everything you need? Do I need to buy anything to prepare for recovery?
I think we have a packet that we kind of recommend that people have and things to have on hand. The hospitals do provide some incidental supplies, but I wouldn't make that my pre-op plan. I would have all the materials that we recommend on hand to.
I think for the most part they send you home in a bra and a binder.
Yeah.
I know for us, when I'm listening to the nurses talk, they suggest getting some just cotton t-shirts, cut it up the middle to wear underneath, bring that with you to the hospital. But as far as like dressings, ointments, are they putting anything on their skin after surgery?
We have a series of dressings that go on in the operating room that can actually last several days. And those can range from plastic dressings that are watertight to actually sometimes we use incisional wound vacs that help with wound healing. And those can last anywhere from 7 to 9 days. As far as specific ointments and that sort of stuff, those are also done on a case-by-case scenario.
Okay, last one, I think we're running out of time, but if there's any more after this, keep adding them in the comments. We'll answer as we can. SIEA, one of my ladies, asked, where is the belly skin actually going when it's moved up to the breast area? Is it visible or is it tucked into the breast? Breast tissue?
So, yeah, good question. So, the breast skin, we try and preserve as much of that as possible. The skin from the abdominal area is only used for 2 reasons. One, if there's just not enough skin in the breast area and that replaces it, or if there's sufficient amount, at least temporarily, that skin is used as a window to see how the underlying tissue is behaving after the transfer. And ideally at a later time point that's removed so that as much of the native breast skin remains as possible, but it's generally one of those 2.
Okay, I lied, one more because this is a good one. A patient said she wants to remove her implants because her body is just doesn't like them, she doesn't feel good, but she loves how her breasts look now. If she does a deep flap, is it going to keep that up implant look, or is it going to be more like a natural breast?
It will be more natural. The one advantage of having an implant prior to a deep flap surgery is that if someone enjoys that look, the healing that's happened on the inside has set up the skin and the tissue around it to behave similarly. But when we place the tissue in there, we can help shape it, and depending on body habitus, get a sufficient amount to replace it in a similar fashion. But once again, implant and tissue behave differently. But I think having done it in that order, there's potential for a good outcome.
Awesome. Any last comments before we sign out of here?
No, my pleasure.
I think we answered a lot of good questions.
Yeah, that's great.
Awesome. Well, you guys, that's it for us. We're talking with Dr. Gassman again. If you have any additional questions, just leave them in the comments of the video. I'm also going to put this up. We'll save it and put it up on the Facebook page later for you guys to see. Otherwise, we'll talk to you later. Thanks so much for joining us.
Bye.
Bye.